I'll take it away. So thank you, everyone, for joining. I'm Leiter, endocrinologist, joined David Mazur, anesthetist, and Subodh Verma, CV surgeon. You all know us. It's a pleasure to talk to you today about the results of NEWTON-CABG, which is a global trial which was run out of St. Mike's, presented in a hotline session at the recent ESC, and published simultaneously in Lancet. So I'm going to give a brief background on lipid lowering, set the stage. David Mazur is going to talk about SLICE, which is another recent trial we've completed, and then Subodh will present the actual data from Newton. So just to give you some background, and here are my disclosures. I don't have to convince any of you that LDL is causal for ASCVD based on multiple lines of evidence, including at this point many randomized controlled trials. We know from the cholesterol treatment trialist collaboration that every 1 millimole per liter reduction in LDL reduces major coronary events 23%, major vascular events by 21%, and this relationship holds for the trials with other lipid-lowering agents as well. So there's nothing magical about statins. We no longer talk about pleiotropic effects. Basically, for any LDL lowering with whatever agent you use, you're going to get similar event reduction. In terms of how much should we lower LDL, you've all seen slides such as this. The lower the mean LDL in the trial, the lower the event rate. People had questioned what happens if you get even lower. Might there be a J shape? But of course, we now have completed results from Improve It, from Odyssey Outcomes, and Fourier, all confirming that not just lower is better, but lowest is best. So just to go through these trials quickly, Fourier, of course, looked at evolocumab added to statin amongst patients with stable ASCVD, largest completed outcome trial, over 27,000 patients, moderate to high dose statin plus evolocumab or placebo, event-driven trial with median follow-up of just 26 months. I'm highlighting the LDL levels because this is going to be relevant to when we talk about Newton. The placebo median LDL was 2.4. Those on evolocumab, 0.8, so about a 59% mean reduction, giving an absolute reduction of 1.5 millimole per liter. All other atherogenic lipoproteins also reduced proportionately. Primary MACE plus endpoint reduced by 15%. Key secondary endpoint, the more traditional MACE, reduced by 20%. No increase in incidence of adverse events, apart from local injection site reactions, even amongst the patients with the lowest LDL levels. Subsequently, we've published the open label extension of Fourier. About 6,600 of the original large cohort received open label evolocumab. So those who were originally on evolocumab continued on it. Those who were on placebo initially were switched, excuse me, to evolocumab, followed for an additional 5 years of follow-up. And here you see on the left what happened in the parent study, and during the open label extension, the curves continue to widen, even though everyone was on evolocumab, even though the median LDL was 0.8 in both groups. If we look at CV mortality, it was not reduced in the original trial. Probably we thought because the duration of follow-up was too short, But with the open label extension, we did see a 23% relative risk reduction. In terms of achieved LDL versus outcomes, so patients weren't randomly assigned to different LDL levels, so this is an association, but those people with the lowest achieved LDL had the lowest likelihood of having either the primary MACE plus endpoint or the key secondary MACE endpoint. Here you see the outcomes by achieved LDL, and across the board, those people with LDLs under 0.5, shown in this purplish color, had the lowest event rates. And if we look at safety, again, even in these people with the lowest LDL levels, there was no increase in any putative adverse events of concern. Other trial Odyssey outcomes, alirocumab added to patients who had a relatively recent ACS in the last year. Similar design, about 19,000 patients randomly assigned to alirocumab or placebo on top of statin, median follow-up of 2.8 years. Again, their MACE plus endpoint reduced by 15%. And we, let me skip that. We also have, so Sean Goodman was very much involved in the trial. He published this in Journal American Heart Association 2023, a longer follow-up of Odyssey outcomes, again showing ongoing significant reductions in death and MACE, and again, safety indistinguishable from placebo. So we have event reductions. Now, let's look at potential mechanisms. So another study done with evolocumab was Glagoff, which tried to answer the question, will adding evolocumab to statin therapy affect the progression of coronary atherosclerosis? So these were patients who had evidence of coronary disease on clinically indicated coronary angiogram with an elevated LDL on stable statin therapy, received, in this case, monthly evolocumab or placebo for 76 weeks. Primary efficacy endpoint nominal change in percent atheroma volume from baseline to week 78 is measured by IVUS. Here you see the LDL levels. So placebo, 2.4. In the evolocumab, the mean was 0.95. And you can see here the percent, those patients on the additional evolocumab, significant reduction in percent atheroma volume. So those people who were continued on statin alone didn't show much progression, but those also on evolocumab showed regression. Here you see Glagoff plotted with other IVUS trials. And you see here the mean on-treatment LDL versus the mean change of percent atheroma volume. So above, if the dot is above the unity line, it means there's progression. If it's below, it means there was a regression. And those trials, so if you have an LDL below around 2, you start to see regression. The lowest the on-treatment LDL, the greater the magnitude of regression. The other relevant trial, Huygens, tried to answer the question, will adding evolocumab to statin therapy modify coronary plaque phenotype? Patients had a non-STEMI, elevated LDL. Again, the addition of monthly evolocumab or placebo for 50 weeks. Primary efficacy endpoint, nominal change in minimum fibrous cap thickness in a matched arterial segment. As you're probably all aware, an increase in FCT indicates a more stable atherosclerotic plaque, and a larger lipid arc is associated with a more vulnerable plaque. And here you see the results. First of all, this is the LDL change over 50 weeks. So we're comparing those on evolocumab 0.7, those on placebo 2.3. So a 1.6 millimole per liter absolute difference in LDL between the two groups. And you see here the primary endpoint, minimum FCT, increased significantly in those patients on the additional evolocumab. Also significant reduction in maximum lipid arc, in the percent change in minimal FCT, and the average minimal FCT for all. So all of these measures of plaque stability going in the improved direction with the addition of evolocumab. And again, this is in milligram per deciliter, but the lower the achieved LDL, the greater the absolute change in minimal fibrous cap thickness. And if you look at the absolute change in LDL, you need about an 80 milligram per deciliter or about a 2 millimole per liter absolute reduction in LDL before you start seeing an increase in fibrous cap thickness. So with that, I'm going to pass it on to David Mazer, who will talk about the SLICE trial.
Okay, thanks very much. So I'll just share my screen. I think. So what I'm going to talk about briefly is the SLICE CEA.
We don't see it yet, David.
Which should be up there momentarily.
Yeah,
which was presented at last year's ESC meeting as a late breaker. So I'm just going to quickly go through it because some of you may not have been familiar with it. This was an investigator-initiated trial. It was funded by Amgen, and those are my disclosures. The only one relevant is some consulting relationship with Amgen. So by way of background, we know that carotid atherosclerosis is the primary etiologic mechanism of ischemic strokes, and plaque size and vulnerability are key determinants of ischemic risk. And within those plaques, there is a presence of a lipid-rich necrotic core, and which is composed of intraplaque hemorrhage and lipid that are the hallmarks of plaque vulnerability. We know, as Larry said, that lipid lowering with statins attenuates carotid lipid accumulation, can reduce lipid-rich necrotic core volume, improve plaque characteristics, and reduce the risk of ischemic strokes. We know, as again Larry pointed out, PCSK9 inhibitors cause marked reduction in LDL and also reduce ischemic events in patients with ASCVD. But whether intensive LDL lowering with PCSK9 inhibition favorably alters plaque characteristics and reduces the lipid-rich necrotic core in patients with asymptomatic severe carotid stenosis was unknown. So we studied patients, adults, who had at least 70% carotid artery stenosis, who were already on moderate and high intensity statins and had at least one of those listed high risk features. And if only one high risk feature was present, then there needed to be evidence of intraplaque hemorrhage. We did a baseline MRI and lab investigations and then randomized patients to either evolocumab 140 milligrams to Q2 weekly or usual care, followed them for 26 weeks or 6 months, and did an end of study MRI and repeat labs. The primary outcome was the change in lipid-rich necrotic core volume from baseline to end of treatment, and secondary outcomes included change in vessel wall and lumen volumes from baseline to end of treatment. So the MRIs were done on a 3 Tesla scanner with the slice levels centered right at the carotid bifurcation. The image analyses were done with vessel mass. The carotid vessels were read by 2 readers who had an interclass correlation, a correlation of greater than 0.9 for all variables. They were blinded to the participant's intervention and the order of scan acquisition. We predefined that occluded vessels would be assigned the highest observed value of IPH and lipid, and we calculated a sample size of 60 would be adequate to provide 85% power to detect a 3.9 cubic millimeter reduction in lipid-rich necrotic core. We used an intent to treat approach, including patients who had evaluable MRI at baseline and follow-up, used ANCOVA, and then conducted several sensitivity analyses, which I'll talk about in a moment. So this shows you a one patient's baseline MRI, and if we focus on the carotid, you can see these 2 dark areas of lipid within the plaque. And after 6 months of treatment at the end of study, you can see that those dark spots, the intraplaque lipid, had almost disappeared. So here's the patient characteristics: predominantly male, age around 72, body mass index of 28, and what we would consider typical either risk factors or manifestations of ASCVD. Their LDLs were around 2 or close to it, and the average carotid stenosis was between 75 to 80%, with around 82 to 86 cubic millimeters of lipid-rich necrotic core volume. They were on typical medications for patients with prevalent ASCVD. And when we looked at the LDL change from baseline to end of study, you can see there was a 44% reduction in LDL with the evolocumab group, whereas the usual care group had a slight increase in their LDL. So this is the data for the primary outcome, lipid-rich necrotic core, evolocumab on the left, usual care on the right, similar at baseline. But after 6 months of treatment with evolocumab, there was an 8.4 cubic millimeter reduction in the evolocumab group, whereas there was significant progression in the usual care group. And this difference between the groups had a p-value of 0.017. When we look at the components of the primary outcome, either intraplaque hemorrhage on the left or vessel wall lipid on the right, you can see there was a significant difference between the groups in terms of IPH, although that was because of greater progression in the usual care group compared to the evolocumab group. Whereas if looking at the vessel wall lipid, there was a very significant reduction in lipid volume within the vessel wall, whereas the usual care group also had progression of lipid in the wall. As mentioned, we did a variety of sensitivity analyses. The primary analysis is on the top. We also looked at all imaged carotids because some people had bilateral carotid disease. We also excluded carotids that progressed to complete occlusion, 2 of which were in the usual care group, and also adjusting for the baseline differences in LDL. And in all cases, the results were significant and consistent with the primary outcome. We also did subgroup analyses stratified by sex, age, baseline LDL, and the presence or absence of intraplaque hemorrhage. And you can see from this forest plot that there was no interaction, and all of these variables, the point estimates were in favor of evolocumab. We also stratified by clinical history of diabetes, CAD, PAD, or stroke or TIA. And again, results were consistent with the primary outcome. The P interaction for diabetes was 0.05. Secondary outcomes are shown here, the vessel wall volume on the left and the vessel lumen volume on the right. And in both cases, there was no difference between groups with these secondary outcomes. We also looked at progression of disease at 6 months. On the left, the primary lipid-rich necrotic core, then the interplaque hemorrhage, and on the right, vessel wall lipid. And you can see that there was a significantly fewer patients in the evolocumab group whose lipid-rich necrotic core volume progressed compared to usual care, and similarly, significant fewer patients on the right-hand side in the evolocumab group whose vessel wall lipid progressed compared to the usual care group. The primary composite and the vessel wall lipid were significant, and in both cases, the number needed to treat to prevent progression was 3. Now, are these results consistent with other studies? Well, there's one small study reported in the Journal of Clinical Lipidology last year, similar design to SLICE in that they had a placebo group and an evolocumab group looking at lipid-rich necrotic core in placebo and treated patients. In this case, they followed patients for 12 months. But I just want to point out that in the placebo group, again, there was significant progression over the 12 months, and whereas the evolocumab group had regression of the lipid-rich necrotic core volume. And if you looked at the lipid-rich necrotic core as a percent of vessel wall, again, a similar effect, progression in the placebo group and regression in the evolocumab group. And then at this year's ESC, there was presentation of the Caruso study, which was another study looking at carotid plaque stabilization and regression with evolocumab. And in this case, they took patients with 50% carotid artery stenosis and an LDL greater than 100 and randomized them to evolocumab plus optimal lipid-lowering therapy. So biweekly evolocumab on top of optimal lipid-lowering therapy, which was rosuvastatin and ezetimibe. The primary endpoint was carotid plaque morphologic stabilization, and this was an ultrasound measured outcome. And they found numerically higher carotid plaque stabilization with evolocumab and lipid-lowering therapy, and there were more shifts from low to high risk types with the statin and ezetimibe group as opposed to the evolocumab group. The secondary endpoint was a change in LDL, and not surprisingly, they found significantly more lowering of LDL with evolocumab. And then somewhat surprisingly, when they looked at clinical outcomes of cardiac death, stroke, MI, coronary or peripheral revascularization, there were significantly fewer patients who had major adverse vascular events with evolocumab compared to the optimal liquid-lowering therapy group alone, and this achieved a significant p-value with a number needed to treat of 8. So I'm going to stop by reminding you that our study found short-term 6-month treatment with evolocumab compared to usual care led to both regression and prevention of progression of lipid-rich necrotic core and its components of interplaque hemorrhage and plaque lipid volume as assessed by MRI in these patients with severe high-risk asymptomatic carotid stenosis. They extend the data that Larry talked about from Glagov and Huygens, and they also provide a mechanistic rationale for the ongoing Vesalius trial. So thanks very much. I guess we'll take questions later on and pass the baton over to Subodh.
Well, thank you very much, David and Larry. Do you see the slides, David and Larry?
Yes.
Like,
Yeah,
is it in the presentation mode?
it is. Yeah.
Okay, great, excellent, thank you. So good afternoon, everyone, and really pleased to present to you the design and the primary results from the NEWTON-CABG CardioLink-15 trial. As Larry mentioned to you, this was a trial that was presented as a hotline at the recent ESC meeting, and it was actually published simultaneously in The Lancet. Just to remind you all, this was a global randomized trial of evolocumab, a PCSK9 inhibitor on saphenous vein graft patency following bypass surgery. And the trial was chaired globally by Dr. Leiter, and Dr. Mazer and I served as the co-principal investigators. It was funded through a investigator-initiated grant from Amgen Canada, for which we are really incredibly grateful. There was a international steering committee that is listed here on the slide that actually included Deepak Bhatt, Peter Uni, Michael Corin, John Mancini from Vancouver, Steve Nichols from Australia, and Dr. Hui Teo from our institution. Now, just by way of background, again, to a cardiology audience, I don't need to remind you all that bypass surgery is done commonly, and there's a lot of it done throughout the world, as you know. Saphenous vein grafts continue to be used quite extensively in bypass surgery. Of course, we're using more arterial grafts, and we're using radial grafts in many patients, along with the lima, of course. But saphenous vein grafts continue to be used in close to 90% of cases globally at the present time. We know that saphenous vein graft failure is common, it's recalcitrant, its mechanisms are unique, and that we've had really no solutions in terms of mitigating saphenous vein graft failure since we started bypass surgery. There's been many hypotheses that have been put forward. Some have related to, soon after surgery, there are technical errors, which we all appreciate. And then there's the concept that these veins get arterialized, and arterialization of the veins can lead to neointimal hyperplasia and smooth muscle cell proliferation, and that process is dominant in the first few years as opposed to atherosclerosis. Others have said thrombosis is more important than intimal hyperplasia, is more important than atherosclerosis, and therefore dual antiplatelet therapy should be beneficial. But there doesn't seem to be, agreement as to whether or not conventional risk factors or conventional atherosclerotic risk factors such as, A1C and LDL and blood pressure and others are important in the short term in mediating saphenous vein graft failure. Now, with respect to LDL cholesterol and saphenous vein grafts, we know, as Larry has mentioned quite elegantly, that LDL cholesterol is causal in atherosclerosis, and post-CABG remains a therapeutic target for long-term secondary prevention. That data remains unequivocal. And as also, Sean Goodman from our own institution led the analyses in people with a history of CABG from the Odyssey outcome study and demonstrated, a consistent benefit with greater absolute risk reduction in these patients who were treated with alirocumab. Other analyses of evolocumab post-CABG in people with, complex PCI or complex revasc, including CABG, has also shown quite significant benefit long-term. But the question that we were trying to address here is whether or not there is a benefit of intensifying LDL cholesterol lowering in the short term on top of statin therapy, regardless of any LDL threshold, to improve vein graft patency. And that is the question that we set out to answer here. Excuse me here, I don't know what's going on with my pointer. Give me a second here. I think I've screwed up. Great. So the objective was to evaluate whether intensive LDL lowering with evolocumab, when initiated early after bypass surgery, in addition to moderate to high intensity statin therapy, reduces 2-year saphenous vein graft failure as assessed by CCTA. So to that aim, these were the patients that we enrolled in the trial, adults who had had a bypass procedure done with at least 2 saphenous vein grafts within the preceding 21 days. So these are sort of really early after after coronary artery bypass graft surgery, and the surgeons would have employed at least 2 saphenous vein grafts to construct the operation. They would have to, by inclusion criteria, be on moderate to high intensity statin therapy, which again, as you all know, is defined as Atorva 40 to 80 or Rezuva 20 to 40. Or if they were on an alternative dose, it had to be clinically justified. They had to be statin intolerant, etc. Exclusion criteria are listed here. What I want to emphasize to you is that we did not pre-specify any specific LDL entry criterion. As long as people had bypass surgery, they had at least 2 veins used during bypass surgery, surgery was done within the preceding 21 days, and they were on moderate to high intensity statin, we just wanted to add evolocumab on top of moderate to high intensity statin right off the bat to see if that would change outcomes at 2 years. So these patients were randomized in a double-blind randomized fashion to evolocumab, 140 milligram every 2 weeks or matching placebo. The primary endpoint was VGDR, which stands for vein graft disease rate, and this is the proportion of saphenous vein grafts with significant stenosis, more than 50%, or total occlusion on a greater than 64 slice CCTA or clinically indicated angiography 24 months following bypass surgery. In addition to this primary endpoint, we had defined secondary endpoints, which evaluated the proportion of saphenous vein grafts that were completely occluded, the proportion of participants who had more than or equal to 1 totally occluded saphenous vein graft at 24 months, and a hierarchical win ratio that included clinical events, in addition to various measures of graft failure, including total plaque volume as shown here. Now, Dr. John Mancini from Vancouver served as the core lab for these assessments. The primary and secondary endpoints were evaluated in a modified intention to treat population, which included all randomized participants who received at least 1 dose of IP and had at least 1 evaluable saphenous vein graft at 24 months. And the safety endpoints, however, were evaluated in the ITT population. Now you see in the next slide, 782 participants from Canada, United States, Hungary, and Australia were randomized at 23 sites in 4 countries, and the baseline characteristics of the patients that we enrolled are shown in this slide. And as you can see here, the mean age was about 66. The majority were male, 85% were male, and the prior myocardial infarction was seen in about 40 to 45% of individuals at baseline. About 17% had a prior history of PCI, and the baseline cardiovascular risk factors were, as you would all expect in a population that underwent bypass surgery. Notably, about 40% of individuals had a history of type 2 had a history of diabetes. The important point with respect to baseline characteristics to be made here is that this was a population that was quite well treated with respect to conventional risk factors. So as you can see, systolic blood pressure at baseline was 123/74. Baseline LDL, as shown here in dark and slightly enlarged font, was 1.85 millimoles per liter. And you'll remember Larry's original comment when he was presenting a few minutes ago that this needs to be considered as we understand and interpret the results. So this was a trial that started out with exceedingly well-treated patients with an LDL of 1.85 millimoles on moderate to high intensity statins. And please notice the A1C was 6.2% across the board and 7% or so in people with diabetes. So, we're really happy to see this actually in a contemporary era of patients post-bypass. Within 21 days post-bypass, at least the patients that we enrolled seemed to have really excellent LDL blood pressure, A1C control. Everybody was on a moderate to high intensity statin, about 100%, and almost 100% on aspirin, and 1/3 were on dual antiplatelet therapy of aspirin and either clopidogrel or ticagrelor. The mean number of days from surgery to randomization was only 13. So, people could get in within 21 days, but it turns out that we randomized people within less than 2 weeks after their index bypass procedure. 70% of the patients that we enrolled had elective procedures, and most of these patients had surgery with the assistance of cardiopulmonary bypass, as shown here. The vein graft harvesting techniques are shown here. 1/3 had open, but the majority actually had endoscopic vein harvest. Everyone received, 95% of patients received a lima, and those that did not receive a lima could have actually been individuals that had an aortic valve replacement or a mitral valve replacement or repair where they needed 2 additional vein grafts. So radials were used infrequently in about 8% of cases. Now, no surprises, evolocumab is a highly effective therapy on top of statins to lower LDL cholesterol, and that is exactly what we found here. That at 24 months, evolocumab group experienced a 52.4% reduction in LDL cholesterol, such that, as you see on the right-hand side of this graph, at 24 months, the LDL concentrations in patients on evolocumab were 0.79 compared to 1.63 in the placebo group. So now we are at really low and ultra low levels of LDL, both in the placebo as well as in the evolocumab treated groups. So shown here are the primary and key secondary outcomes. And you can see here at 24 months, the primary endpoint, which is defined as the proportion of saphenous vein grafts with significant stenosis or total occlusion, that occurred in 19.7 versus 21.7% of patients. Odds ratio 1.13. The 95% confidence intervals cross the line of unity, and a non-statistically significant p-value. The key secondary outcomes, which are looking at the proportion of saphenous vein grafts that were totally occluded and the proportion of participants who had one or more saphenous vein graft occluded, were 19.6. Sorry, where were they? 16 and 27.8% respectively, no difference with evolocumab. So, when you look at these results, there's a few things that need to be kept in mind. And that is that even in 2025, on top of, all of the advances that we made in surgery, excellent LDL control, excellent blood pressure control, A1C control, etc., with surgery being done in, experienced centers globally, saphenous vein graft failure is common and remains recalcitrant. And that's a key observation that you see here, with rates that are seen at 2 years in the placebo group being quite high. And that further LDL cholesterol intensification with evolocumab did not change this outcome. The hierarchical win ratio, which included cardiovascular death, MI, coronary revasc, measures of saphenous vein graft occlusion, total plaque volume, overall was not different. This was 0.92 as shown here with a p-value of 0.39. We also looked at saphenous vein graft total plaque volume, and this showed no difference between evolocumab and placebo-treated patients, and the clinical events were low at 2 years, and there were no difference between the two arms. We did some analyses by pre-specified subgroups by age, sex, LDL cholesterol, presence or absence of diabetes, smoking, or heart failure, and they were generally consistent across the cohort. So the key takeaways from Newton-CABG, and we're happy to have a discussion around it, is first and foremost, we understand that this is not a trial questioning the efficacy of evolocumab and cardiovascular risk reduction in CABG patients. We know that the long-term success of LDL cholesterol lowering remains clearly evaluated in trials like FOURIER, as Larry has mentioned. But this strategy is not a strategy definitively based on our evaluation on top of statin therapy for short-term 2-year vein graft failure. Vein graft failure remains very common and appears to have a mechanism that may be distinct from native coronary atherosclerosis at this point in time. And we would suggest that novel strategies beyond LDL cholesterol lowering that target remodeling, thrombosis, or inflammation may be required. We acknowledge limitations. The relative LDL cholesterol reduction was consistent with FOURIER and other trials, but the absolute reduction was smaller, and that's because we started with a lower LDL cholesterol level at baseline. The follow-up was relatively short. At 2 years, the trial was not powered for clinical outcomes, but was appropriately powered for vein graft outcomes, and technical graft failure was not evaluated immediately post-surgery. And this was Newton-CABG was a trial done during COVID. And as you all know, initially the intention was to do a CT scan at baseline and ensure that the veins were open prior to randomization. That protocol required an amendment because during COVID, getting access to the CT scan for research was actually not feasible. So in summary, among individuals with a median baseline LDL of 1.85 millimoles per liter, all treated with moderate to high intensity statin, the addition of evolocumab within 12 days post-CABG surgery did not improve 24-month saphenous vein graft patency. Saphenous vein graft disease rate remained high despite optimal A1C blood pressure and LDL cholesterol at baseline. These data highlight the need for alternative biological targets and mechanistic interventions to address this clinical challenge. And we have a lot of people to thank here that are listed here, including members of the DSMB and Dr. And the adjudication members on adjudication committee. David Fitchett played an important role on adjudication of the ECGs, and we're very grateful to him. And of course, we're grateful to the Lancet. As you know, Lancet and the New England Journal are always fighting for who has the higher impact factor. It turns out that the flavor of this year is that the Lancet's impact factor is higher than the impact factor of the New England Journal. And we're really delighted that the Lancet actually published this simultaneously, with the hotline presentation. So with that, I think back to you, Qiming, and then Larry, David, and I are delighted to have any discussion. There were a few other things at the ESC that were noteworthy, but I don't think we have time to go into them at the present time. So.